Welcome back. In this lesson, and actually in the next 3 lessons moving forward, we're going to talk specifically about the use of specialty appliances. And what I mean by specialty appliances is they're definitely not used routinely on an everyday basis. They have some very specific functions. So when we think about the specialized appliances, typically we're talking about appliances that are used to position the mandible anteriorly, or we're talking about a posterior pivot, which is an appliance that has only posterior occlusion, no anterior occlusion, or we're talking about a full coverage soft appliance. So basically that describes what the next 3 lessons are going to be, is those 3 types of appliances. If we look at an anterior repositioning appliance, the first ones that I was exposed to looked like the illustration you see. Back around late 1970s, 1980, Farah and McCarty designed an appliance specifically to try and hold the mandible forward, and the purpose of it at the time was to actually try and recapture discs. So if you had a disc that was anteriorly displaced and the patient was clicking and popping, the concept was that you would hold the patient forward, and in that process you would try and get the disc back in position. So what the appliance actually did is it had a flange that went down the lingual of the lower anteriors. And because that flange was so large, as you can see in the illustration, the mandible had to come forward to close around it. So effectively what you were going to do was you were going to try and have the patient open wide so they would get on the disc, and then you would have the patient close in a protruded position, slowly start to go back. And as they went back, you would want the patient to stop before the disc clicked off, and you would make a bite record there. And the concept then would be you would build this appliance in that position, and because it is a directive appliance, that is, it makes the patient close forward, it makes the patient stay on the disc. So effectively, that's the whole concept behind this kind of appliance. So if we were to look at it just in terms of an illustration, you would see on the left screen where we have the condyle up behind the disc, and you can see the simulation from the cadaver video where now the condyle pops off. You would have the patient open till they popped on and then start to close, and before they pop off, stop. You'd make your bite record, and you would try and then use that appliance to recapture that disc in position. I have to tell you, my experience with those appliances is I made a lot of them in the early 1980s. The concept was you would leave them in 6 to 12 months, then you'd start reducing that ramp, and as you reduce the ramp, the mandible would go back a little farther, and the concept was you could reduce it till you could get rid of the appliance and the disc would stay in place. That was not my experience. I bet my success rate at recapturing discs was less than 5%, if that. So today we typically don't think about those kinds of appliances, except if you have a patient that had normal jaw joints and they had some sort of trauma, head and neck trauma, and now they're clicking or popping. You may make one of these appliances for a very short term, let's say 2 weeks to 4 weeks, to see if in fact you can capture the disc and get some healing of the posterior ligament. But other than that, it's not a common appliance to be used anymore. Now, what is a more common appliance is this type of an appliance. This is a patient that has in fact displaced disc, complete displacement on both left and right joints. She was very uncomfortable when her condyles would seat, so this lower appliance was made with her in a protruded position, and the lower appliance actually has occlusion. It has fossa and cusp form, and it makes her bite in that forward position. It doesn't force her to stay there. It trains her muscles that this is where her new occlusion is. In her case, she's actually very comfortable in that position. And in this kind of a patient, if the joints adapt, which often they do, they are actually able to go back into a more retruded position without pain. So what this appliance does is it directs them where to close. It doesn't forcefully hold them where to close. And we typically think about this appliance usually as a pain management appliance, typically for joints that are painful when you seat the condyle. So essentially what you're doing is you're using occlusal anatomy to try and prevent the condyle from moving into a retruded position. Now, far and away, today, the most common directive appliances are actually snore appliances or apneic appliances. And I put this photo in just because it's kind of funny to me that you can actually buy a SnoreGuard for $19.99 on Amazon. But obviously, these kinds of SnoreGuards where you simply boil them and bite into them, you really can't control the occlusion very much. The more traditional style appliances that we think of for snoring and for apnea, we have a much more control over in terms of how far we protrude the mandible. So when we talk about these kinds of appliances, we really are talking typically about an appliance that's going to be used very specifically at night to try and manage an airway issue. Now, I'm not going to spend a lot of time on these kinds of appliances. It's not necessarily my area of expertise, but I do want to make people aware that in fact these types of appliances do have some risks associated with them, especially changing occlusions, where after you wear one for a period of a year or two, your bite may not be the same as it used to be, and I'll show you an example of that. In terms of results, these appliances can be actually quite effective, and they can be effective both at managing bruxism if the bruxism happens to be related to the airway issue. They also can be effective at managing the oxygen desaturation levels because they do bring the mandible forward, which brings the tongue forward, which gives you more space for breathing. So in this particular study, it's a comparison between a mandibular advancement device and a full coverage maxillary appliance. And what I do want to point out is even the full coverage maxillary appliance has a positive impact for these patients on reducing their bruxism. Classically, we would think that that full coverage maxillary appliance was impacting their bruxism because it changed their occlusion. But if in fact that patient's bruxism is related to an airway issue, even a full coverage appliance that doesn't hold the mandible forward but opens the vertical dimension can in fact provide more space for the tongue and improve breathing. So in this study, there were 13 people that were diagnosed with intense bruxism. They got 2 different kinds of appliances. The mandibular advancement device was set with total freedom at one point, so it didn't position the mandible forward. The mandible was brought 40% forward and then tested, and then 75% forward and tested. Interesting in terms of the number of bruxism events per hour, the full coverage appliance actually reduced the number of events 42% per hour. And again, as I said, that may not have anything to do with the change in the occlusion. It may have a lot more to do, in fact, with the fact that this group of people did have apnea, and in this group of people, opening up the vertical did provide for increased airflow. If you compare it, the mandibular advancement device did better. The mandibular advancement device reduced bruxism about 60 to 62% in this particular group of people. The challenge of them is they have side effects. And out of this group, of the 13 patients that wore these different appliances, 8 of the 13 complained about sensitivity or pain on either the gingiva or the teeth when the mandibular advancement device was activated to hold them forward. My point in saying this is if you can manage the patient's airway without pulling the mandible forward, you probably will get fewer side effects long term. Now, what's the other risk of using these kinds of appliances? The other risk is a posterior open bite. And the posterior open bite could be because of joint changes, tooth position changes, lateral pterygoid changes. Nobody seems to know. Nobody seems to have a good handle on specifically why are some of these people not able to get back into their normal occlusion again. Some of them are fairly extreme. This was a case that was posted on Spear Talk. 2016, you can see the patient's in occlusion. The patient received a mandibular advancement device for airway purposes. 2018, that patient, that's the occlusion. They can't get back into their posterior teeth anymore. And as I said, that could be eruption of anterior teeth, could be intrusion of posterior teeth, it could be pterygoid muscle, it could be joint changes. But you know, if we look at what Jeff Rouse and Greg Kinzer did with their Seattle protocol in terms of managing airway patients, they really tried to create a 6-step protocol where if you can avoid pulling somebody's mandible forward, you do it, because if you can get the results without doing that, you can avoid this risk. And just to give you an idea, this happens to be a a study that had 34 patients with obstructive apnea. They had them wear mandibular advancement devices for 2 years, and basically 2 patterns of open bite were described. 3 people got bilateral posterior open bites with attrition of the anterior teeth, and 5 people developed unilateral open bites. So roughly 35% of the subjects over a 2-year period. So continuing on then with our chart of what appliances might we think of when, typically if we really think about a full coverage directive appliance, I would think about it as something I would use when I can't seat joints completely. In other words, if the patient's uncomfortable when you try and seat the condyle, holding them forward slightly and giving them an occlusion forward in an appliance can keep them comfortable. And then certainly if you do need to advance the mandible because of airway concerns, that would be the other time you would use this type of appliance. So what we're going to do next is look at an appliance that in fact is primarily only used for joint patients, and that will be the posterior pivot. So I hope this made sense to you, and I look forward to seeing you soon.